Okay, great. Welcome back to the final discussion, which is going to be a really summary of your group discussions. So I did rotate through the three groups. There seemed to be lots of really good discussion ongoing. So we have half an hour now for each of the groups to report back. So that will be led by the rapporteur, hopefully helped by the chair, and anyone else within the group, of course, is welcome to chip in. So we'll see how the discussion goes. I mean, we want this now to try and be interactive, so it shouldn't be limited to the people in that group. And we have roughly 10 minutes per breakout group at this stage, and then we just need to try and wrap up and see what people would like to do next in terms of our action plan. First up then, we'll just go through the numbering on the agenda. So it was, how can we further develop the utility of PRS? So Catherine is rapporteur and Chantal was chair. So over to you both.
Yeah, thanks, Ewan. So we had a very lively discussion. There were a big diversity of people in our group, including several of the speakers and an MHRA representative. So it was really interesting to see the full diversity. I'm going to talk about four things. I'm going to talk about evidence, how we could move polygenic risk scores further, what the barriers are, and then where we think the easy wins are. So to start with the evidence, there was a big spectrum of opinions here, from some of the evidence that is based on existing studies such as UK Biobank. It's very large, it's got a lot of data, and some what Vincent Plal presented showed that there's a lot of really strong evidence there that polygenic risk scores could be very effective, whereas other people were saying, well, that's not representative, it won't be acceptable for regulatory, we need something that's much specific here. But obviously we can't run clinical trials, which might be the gold standard in everything that we want to do here. And in most risk assessments are not based on clinical trials, so maybe that's not what the route that we should be going down here, and certainly a much more pragmatic route to build up that evidence would be to the trials we have, the studies we have available, doing in silico trials, and seeing what we can do from the extensive evidence that we have available without building new trials for everything we want to progress forward. But there was a strong feeling that the evidence in some ways already existed, and the real next step was how we could really use that evidence and convince people and go to the next level. So coming on to the how we do that, one of the challenges, picking up again on the prostate, for example, where the percent of the highest polygenic risk scores had a really high level of disease risk, which you would absolutely want to know out, but to be able to do that, you have to genotype or sequence everyone, and so that's a challenge. It might be difficult to show that it's cost effective, and we had various discussions about genotype data versus whole genome sequencing, which is clearly the direction that the NHS is going, and whether we would get to the point where every young adult had their whole genome sequence available as part of the healthcare record, and that would be a natural use of poly risk scores to see how we could predict. We discussed democratization with the idea that it's easy to get your genotype data from 23andMe or other providers. Should we be using that? But of course, anything we do in genetics has to be relevant to everyone, and we should absolutely not be doing anything where genetics will exacerbate existing health inequalities. But however we do that, there needs to be a very clear outcome that we can act on. So in terms of the wins, where that outcome exists, looked back to pharmacogenetics, but we think that there are some easy wins there, but it's been very difficult to move that into clinical care. I suspect that some of the same barriers exist for polygenic risk scores. One, I think, sweet spot perhaps might be in rare variants where we have people with FH variants with BRCA1, PALB2, polygenic risk score spreads their risk quite considerably. Those are people that we already have genetic information on. They're a small group of people. Polygenic risk scores would allow a more a better decision to be made. So I think the strong feeling starting with small groups of people would be a good start there, and we all were very positive about the Our Future Health study with sequence data in a large number of people will be very exciting. That leaves me the barriers, of which there are several. So I've touched on the regulatory barriers that FDA, MHRA, the assay that we use here, the that we construct just don't fit with standard mechanisms that they use. 6 million imputed variants, doesn't make something that fit regulatory models well. There's a huge amount of public education needed, education of clinicians of how to use this information. And we talked about the importance of genetic counsellors to communicate this. The ancestry we've already touched on in the talks, but I didn't want to leave that out. And then we felt that the big barriers was the IT system in the NHS and making sure that however we collected genetic information, that tying that up with the phenotype and making it accessible was going to be key, and there was hesitations about whether the NHS IT system was ready for that. I'll finish there.
That was very clear. Thank you, Catherine. Chantal, did you have anything to add?
No, all captured.
Yeah, that's great. Any quick questions or comments from anyone else, either in that group or from the whole group here? I think it's interesting the parallels you draw with pharmacogenomics around the barriers, and as you well know, we've had these actionable variants for years that we still are only just starting to implement, the barriers and the wins are there in the same context. But I think my impression of the barriers to pharmacogenomics is that we're overcoming those now. I think things have shifted, and there is clearly a movement, which hopefully PRSs will also move along with, because I think we are getting to the point now where the vision of polygenic genotyping PRSs available across the population are a reality, aren't they? So. Great. Yeah, and just one thing that I've been impressed by the data on, and we didn't have time to discuss when I was in your group, I hadn't heard much of it coming up earlier, was around screening. So did you touch upon that at all? So certainly, the data on breast cancer screening, mammography and bowel screening, certainly an area that we're interested in.
We didn't touch on it.
So I think we kind of did very briefly, just in terms of some of the challenges bit, i.e., you're then looking at a broad population as your starting point, and how do you actually get the data, do and demonstrate efficiencies, cost effectiveness really in those situations where you're having to test a wide variety of people. And then we kind of moved on to, when do you test? Do you test, is it in everyone's records? Do you use it in multiple ways?
Yeah. And in terms of costs, I mean, I know sequencing costs are coming down, but in the pharmacogenomics NHS discussions that we'd had, we were very much all moving towards just genotyping arrays, given how cheap they are. And I think that makes the cost effectiveness so much of a bigger win, doesn't it? It's not beyond the bounds of possibility to have genotyping arrays on everybody. less than the cost of a chest X-ray is part of my standards.
Yeah. And do you think that's feasible? Do you think that's feasible, Ewan? Can I?
Well, I mean, I just may be hopelessly naive, but certainly that's a vision that's the vision. I'm looking at Alex on my screen that we in Dundee have. I mean, we're very much thinking population based. The whole population is at a certain age and is genotyped on an array, and then that's all embedded in the medical records, and that certainly changes the whole paradigm for pharmacogenomics as it for PRS.
Changes not just for pharmacogenomics, but the whole healthcare paradigm, full stop. I mean, it's because it does just in terms of screening. I guess we talked a bit about screening in our group, but you know, I think that's my view of most of what we discuss is that everything in terms of the way we think about healthcare is turned on its head as a consequence of this technology and the potential for this technology, especially when you have genome-wide data. So it's we have to stop thinking in the same healthcare paradigms that we're traditionally used to.
Yeah. Good. Okay, that's great. Well, thank you to that whole group. And then we should move on to the next group, which was what will be the challenges and opportunities of implementing PRS into clinical practice. And this was chaired by Nick, and Alex was the rapporteur.
Yeah, so we had a very interesting chat. I have to say, many of the things that we chatted about are very, very similar, really, in terms of context to the last conversation. So I guess it will be building on what we've already discussed already. But I guess some other views. I mean, we started off really thinking about the whole regulatory approach, and that was reflected by some of the things that we heard earlier on in the meeting, particularly around the need to standardize or have standardized test, and the fact that the test for a polygenic risk score is built within a genome-wide or whole genome sequencing context, so that you have the test as part of a multitude of other tests as well. And so when you're thinking about regulating a polygenic risk score, you're also thinking about regulating in the same context all of the other potential pharmacogenetic and other tests, rare variants as well, if you're doing whole genome sequencing, for example. And then the whole headache of regulation, in the sense that there are so many different scenarios which would need to be regulated. In other words, the whole spectrum of ways that the polygenic risk score could be used for screening, but also for intervention, et cetera, across different populations, but also different phenotypes. So people, for instance, who with high cholesterol, for example, might need a different risk score for those that have low cholesterol, for example. And you know, I was thinking about this in terms of the perfect drug. I mean, a drug goes to market, but then several Me Too drugs come later on, which maybe have different nuanced metabolic profiles, but nevertheless, it's still a marketed drug. And so, when do you draw the line of saying this is now a score that can be used, and in which case, and who would be the regulatory body for that, and how would that be adjudicated and decided? Multiple different bodies potentially could be regulating on that, and I think that when it comes to pharmacogenetics as well, then there's potentially a whole other regulatory body that would need to get involved as well. So that then leads on to the whole issue of evidence generation and how we regulators need evidence in order to be able to regulate. And again, in the context of fragmentation of these different approaches, how do you ever generate the evidence that's required across so many different potential paradigms? I've just written down here a genome-wide score or even a genome-wide chip has implications for a healthcare-wide approach because it can affect right the way across the healthcare spectrum. And so when you think about, for instance, funding, one of the conversations that we had was who would pay for and who would fund that, and how would you cost it? It has implications because if you're just thinking about one test, but then you're getting a genome-wide scan done or a whole genome sequencing done, you're paying for millions of tests quite literally, and so trying to think about how a healthcare service would cost that and for implementation is another major way of problematic in terms of thinking about it. We were thinking about the sort of main use cases of practical ways in which this can be introduced and in what sort of circumstances. And I think the group felt that really cancer and cardiovascular paradigms or healthcare situations would be the main two areas where polygenic risk scores would have potentially huge benefits in terms of changing or predicting risk. And we discussed a little bit around how they would be used in terms of either screening or risk prediction. And from there, we decided that there was probably this concept that the whole area of healthcare and approach would change as a consequence, perhaps, of population-wide availability of this genetic test. And when would that become available? At birth, or at the age of 20, or when? And how does that get decided on a national scale? And then there is the whole issue of education and training. There is the physician element for training physicians, for how to think about how to manage polygenic risk scores and how to incorporate them into their pathways. But there's also the concept of patient education and other healthcare workers who are involved in the whole patient pathway. And I guess we did think a little bit about the whole issue of education and training is very important, because already as physicians, we already don't do what we know we should do with the information that we already have. We don't do it well enough. I mean, I'm talking about blood pressure management, and I'm sure in the diabetes world, you will admit that diabetologists don't manage blood sugar as well as they probably could and should. And does this mean that we can start moving the impetus or the or framing healthcare in terms of patient-owned data, in terms of patients now having their own healthcare on their device, in terms of telling them that they have these particular risk variants or this particular risk of cardiovascular disease or cancer, and then as a consequence of that, them seeking out healthcare in advice and support and screening based on their risk. So in other words, putting this in patients' hands, which is all about personalization of medicine anyway, which is so that might be that these things need to change in terms of how we think about the whole healthcare model in terms of patient-held records. And finally, in terms of informatics, I think that was a very good point that was made by the last group, and certainly our primary care doctors who were on our group felt that within primary care there are very good and well developed systems for being able to interact with advice about risk. But again, in terms of pragmatics, and primary care doctors are always extremely pragmatic, is the, I suppose, the patient populations that they deal with on an everyday basis. How does that, what's the external validity when you have someone with multimorbidity and their polygenic risk score, for example, is telling you to intervene with an antiplatelet or a statin or even an anticoagulant when they have their frailty score is extremely high as well. So there are all sorts of realistic elements to how we practice realistic medicine using these risk scores.
Okay, good. So we should give Nick a chance to come in. Was there anything you wanted to add to that, Nick?
Thank you. Yeah, no, thanks, Alex, for doing a great summary there. No, we had a great group. It was really good conversation. I think the take home that I had was that, I think everybody's really positive and optimistic about the use of polygenic risk scores. But I think everybody sees a value for those in clinical practice, and if we can overcome the barriers to implementation, then there's very definitely, a willingness to use those. So and probably in a much shorter time frame than I'd probably anticipated before this meeting as well, which is really encouraging. So yeah, thank you.
Okay, thanks, Nick. And from that group, any other comments, or from anyone else before we move on to the next group?
Hi. Well, hi there.
Hi, Nadine.
You probably got hi there. I was going to ask, thinking about the model in the future, that if we have full sequencing available, say in the primary care records, there will have to be some sort of mechanism to decide when can we create decision support with this. So if you look at primary care records at the moment, there's been a plethora of different risk scores that turn up and alert you, whether it be fever, whether it be medication. And it's actually, in a way, maybe this is something for MHRA, is actually there needs to be some sort of regulation of how this is actually done in the real world.
Yeah, I mean, I absolutely think that's a very fair point. And obviously the sequence is unchangeable, but the interpretation of the sequence clearly will change and be constantly updated. And how do you do that in a way that is, well, I suppose it just comes back to all the discussions we just had, regulated, standardized, version controlled. GPs obviously need to know that things are changing, new risk scores are being applied. Yeah, I mean, it's
certainly, if I could just interrupt there on that point, we have a very pragmatic professor of primary care who we've worked with, who very often just says he turns all of those things off because he gets so completely fatigued by being warned about this, that, and the other thing, and he just clicks through them because. And I think that was part of the conversation we had in the real world. I mean. Primary care people are very, very pragmatic about, really managing the patients in front of them. And in the real world, the translation of all the things that we are fantasizing about over here, how do they really apply to the everyday practice of the patient in front of you? I don't think we'll ever resolve that particular problem.
No. Okay, good. And we shouldn't go there now because otherwise we'll be here for hours. So let's move on. So the third group then was on ethical issues associated with the use of PRS. Chair was Philippa and rapporteur was Michelle.
Hi, yes. If it's okay, I'm just going to read my notes to you. But we had about 6 major themes that we came across about the ethical issues around PRS. And as a group, we identified them based majority on, I think, this sort of context. But coming from South Africa, every now and then I will jump into what I think is we should be aware of the other contexts that might be applicable when we think about ethical issues around PRS. So the first one was the current level of imprecision around polygenic risk scores, that understanding that there's no standardized definitions, there's no standardized measures or methodological approaches in the development and assessment of PRS, and also acknowledging that the variability in PRS values across diseases and their actionability and their usefulness of the scores remains to be seen for a large number of diseases. I think we also came across the point that the reliance of genomic data derived mostly from European ancestry individuals and the high levels of imputed data is still a major problem. And I think linked to that is that the high reliance of European ancestry individuals is linked to potentially exacerbating health disparity across populations in the future. We also came to the point around genetic exceptionalism. Is the information provided by the PRS really that different to or better than other biomarkers that are currently used for risk stratification? And I think that's an important note, that it needs to be very clear in distinguishing between the use of PRS as a standalone measure or using it with or the other measures that are currently used in clinical risk stratification. We then thought about clinical interpretation. How do you interpret the results of a PRS and document the result when the evidence base is so small and clinical guidelines are still not present? How do you manage the potential for misinterpretation? And what is the role and responsibility of the clinician and allied health workers, in this case genetic counselors, in interpreting the PRS, sharing the results to the patient, and then shifting their prevention and treatment strategies? And regarding the ethical duty of care associated with secondary findings, at what point is it justified to return to the patient, and how regularly do we do so? And we also looked at screening and risk stratification programs. What is the inclusion and exclusion criteria for these, and what would be the patient uptake of these, given that they would be different to what would normally be expected, given age or gender? We also thought about the communication to public around PRS, that it needs to have clear messaging around the role and the contribution that PRS plays in the disease risk. And we also need to manage the risk of overloading the patient with information and explain the role of genetics in their disease over lifetime. We also thought about information collection and storage. So what is the role and who is involved in collecting and storing of information associated with PRSs? What information is stored, given that we don't necessarily have clinical guidelines associated with PRS as yet? And who has access to this information, and how is the information relating to PRS shared with the patient? And then another point that we raised, and I think it might be more from my background, is at what point is the opportunity cost of going into precision medicine-based interventions such as PRS over and above that of public health interventions? And then the other one that we thought about is, and I think it's a key question, is what is the risk of not using approaches such as PRS to risk prediction? Which we didn't get to explore much further, but I think that's a big topic in itself. I hope I've captured what our group said, but I'm relying on Philippa to add to that. Okay,
that's great. Again, really clear. Thank you. Philippa, anything to add?
Yeah, no, that was excellent, Michelle. Thank you. Yeah, I think just reflecting on that, an awful lot of the issues, and you've probably noticed that some of them were not so much ethical as practical or social. Some of the things were, we thought, perhaps not unique to polygenic risk. It's more around genetics, but polygenic was kind of exacerbating perhaps existing ethical concerns. And I think a lot of it just came down to the context of use, so, you know, the population, the disease, the conditions, and also because of the complexity of the data behind them and the methods by which, you know, they're arrived at, that further exacerbated the issues of communication, potentially. And that applied, particularly we were talking about patients and return of results to patients and so on, but also it would very much apply to, as referred to in the previous session, health professionals, and we also talked about regulators as well.
Yep, and certainly quite a lot of overlapping themes. In fact, there was, which is great when we come to think around what can we draw from this whole thing. Any other comments or questions? I think Alex has a hand up.
Yes, I mean, the whole ethics thing is very important and fascinating, and I just would like to throw this open to everyone here. So, what do people think about the situation whereby sitting in databases at the moment, and in our databases, for instance, that you and I work with at the University of Dundee, we have many thousands of individuals who we already know have an enormous cardiovascular risk score, and we know this, and also potentially we could calculate their prostate score as well, for example, and yet we're not sharing that with our patients, even though potentially it's sitting there. So that's the inverse of what I guess you guys have been talking about. And do you think that, and I guess the other thing is UK Biobank, 500,000 people, they all have that data sitting there. And I'm a clinician and I work with patients, and one of the things that I give people is clopidogrel a lot of the time, and we know that 1 in 4 people the clopidogrel doesn't work, and yet sitting over there we have the data. So do you think? And I've always wondered whether I could get sued by somebody's relative saying, "But you had my dad's DNA sitting in your bioresource, and why didn't you use it when you could have used that information to stop him having another event?" I'm just putting it out there as a question around ethics, because we are going to start. All of us are involved in large databases, I'm sure, and larger and larger and larger proportions of the population are going to have genetic data sitting in databases, and should it not be being used already in the clinical context where there are obvious places where it could be used?
Thank you, Alex. So just given we're 10 minutes from the end, and you bring up that huge topic, which of course has been, to some extent, has been widely debated, the ethics of genetic testing for research and disclosure of results. But I absolutely agree with where you're coming from, and it is difficult when we know that we have results that we haven't disclosed to patients because of their consent, of course, in those studies. Sandy, did I see you waved your hand?
I did.
Did you?
Just, well, on that point that was just made, I do think you need and deserve clarification as to whether you'll be sued for doing or for not doing something. That situation needs to be clarified. And I think this might be controversial in these circles, but with the polygenic scores, there is scope, and this is an existing problem, for things like new types of over-medicalization, or having people overly concerned or prematurely concerned, or not having as open a future as perhaps they ought to, especially if we start introducing whole genome sequencing at birth or such measures. So I do think we just need to keep that in mind. And that if we're going to use polygenic scores ever to say to someone, look, you need to watch that because of this, the converse actually I think perhaps should be true, which is actually people can afford to not watch that if their score is a certain way. It can't just be asymmetrical in favor of promoting a certain vision of health. It needs to be a bit fairer than that. And after a year or two of a pandemic, people's notions of risk may also have been recalibrated, and that's perhaps valid.
Very good point.
Yeah, great. Thanks, Sandy. Okay, so any other comments or questions? If not, we should move to bring the day to a close. So the final part on the agenda was close and action plan, and so I did pick Munir's brains earlier around what he had envisaged around an action plan, and he was very much open to hear what people thought, and whether or not there was any particular drive to take the ideas forward from this discussion. Certainly what we've done in the past, not for all of the events that we've run from the network, but for a number, is that we've sort of done written a position statement from the UK Stratified Medicine and Pharmacogenomics Consortium, and it would be interesting to hear if there is appetite for that. There's a lot of stuff out there at the moment around PRSs, and we don't want to just duplicate what's there, but I think certainly the angle of what we've been discussing today around the utility, the implementation, the ethics, in those discussion points that we've just been having, I think could be something that we as a group might want to take forward. So or is there any other particular areas that you feel we should be addressing, or any other groups that we should be linking with? Because of course there's lots of people doing PRSs. So I guess firstly on the point around a position paper on this, and what I don't want to do is I don't think we should be reproducing what's just come out, and so we'd need to think carefully around that before we took the time and the effort to produce this. Thoughts?
One of the things I think that would be very valuable to incorporate into any position paper would be some pragmatic roadmap for evidence generation, and how that would be achieved. Because I think most people in the room here agree that that precision medicine, and at least polygenically informed precision medicine is something that could and should be happening, and there are places in which it could be delivered. But how, given how diffuse it all is, and how problematic it would be for any, or inefficient it would be to generate evidence for every single scenario, how we might want to inform a roadmap for pragmatic evidence generation in the NHS for implementation of polygenic risk scores, and how that would be achieved. I think that's something that's really critical in terms of changing the roadmap for the future.
Okay. So I'm sensing from that response, at least, that there is an interest there in terms of producing this. I mean, anybody else? I should comment that the oh, sorry, Nadeem. Yes, you've got your hand up. Sorry.
Sorry, you're frozen. Hi. I was just going to say there, Ewan, that what we've used in our previous papers, if you use the ACE framework and say what are the questions within each of those domains of the ACE framework that are needed to develop testing and implementing it. And so we've used it for specific tests and for family history, and it's quite useful as a template, and it identifies what research can be done and can't be done. Okay.
That's very helpful. I have to acknowledge I don't know the ACE framework, but I'm sure I can find out what it is.
Yeah, I'll send you something.
Nick?
Yeah, thanks. I mean, one thought was whether we can frame our position statement relative to the issues highlighted in the recent PHG Foundation report. So maybe addressing some of those issues that are highlighted, and saying that the group had a discussion based on quite a number of those key points that were raised in that excellent report.
Yeah, that sounds a good idea. We obviously have people from PHG Foundation here, so any comments on that?
Sure. I mean, that was focused on clinical utility, wasn't it, Chantal, in particular? Obviously, there's much wider issues that you could include, but it'd be a good starting point. I think that's why it's fair to say you didn't set out to do a report on clinical utility. It was just starting to look at PRS, and that was the issue that kept coming up. So we had to almost sort of halt operations and say, hang on, we can't really carry on thinking about this until we thought about clinical utility as a concept.
Yeah.
Yeah. Okay, but certainly I agree those aspects where we've discussed today around clinical utility, we could try and pick out some of the key challenges that you've identified in your report and see whether or not we can at least have a position on those. Okay, I mean, to some extent, I guess it's easy for everyone to think it's a great idea if they're not doing the work. What people don't realise is traditionally the rapporteurs take on some of this work, obviously with chairs and Munir and I believe myself. What's been particularly good about today is that we obviously have it all recorded. So we've got all of the talks and all of the discussion available. So to some extent, it could be around just getting onto paper what we've just been discussing. Okay, so I can see rapporteurs nodding, so that's good.
Yeah, I'm happy to work with Alex on that.
Yeah, great.
Yeah.
In which case, I'll take that back to Munir. I suspect Munir would be more than happy to have this happen and not necessarily have a huge amount of input into it, given everything else that is up to at the minute. But I personally think it's been a great day, some really useful discussion. And I think we do have a lot that we can say that should hopefully be informative. And I think on that note, unless there's anything else, we're 5 minutes ahead of schedule, but I think we should probably bring the meeting to a close. I should just take the opportunity to thank Nathan for everything running so smoothly. You're a brilliant Zoom maestro, Nathan. And that was fantastic. Yeah, do keep an eye out on the Pharmacogenetics and Stratified Medicine Network web page. There are other meetings planned and coming up. I don't know what the next one is. Nathan, have we got that fixed?
Yeah, so the next one we're planning is the annual open meeting in July.
Okay.
There are some workshops in September and October, but we're still finalising the details for those.
Okay, so hopefully we'll all catch up again in July then for the open meeting. Good. Okay, great. Thanks everyone for the time.